Hello everyone, in this video we are going to look at images of a pediatric patient who presented to the emergency department as a stroke code. Patient presented with acute onset of left-sided weakness. Patient initially underwent CT head and CT angiogram as part of stroke protocol. Let's look at the CT head images. On the CT head images, there was no findings of acute hemorrhage or obvious mass. There was no obvious findings to suggest acute territorial infarction. The gray white matter differentiation was preserved. Subsequently, the patient underwent CT angiogram. On the CT angiogram images, there was no evidence of large vessel occlusion, both intracranially and extracranially. Patient subsequently underwent MRI brain examination as part of further workup for potential stroke. On the MRI images, we can see high signal in bilateral centrum semi-ovale with corresponding low ADC signal consistent with true restricted diffusion. However, there is no corresponding flare hyper intensity, no enhancement on post-contrast images. Also, as I scroll down further, you can also see true restricted diffusion involving splenium of corpus callosum extending into bilateral forceps major, again without corresponding flare hyperintensity or post-contrast enhancement. So we have a pediatric patient who presented with stroke-like symptoms with true restricted diffusion in bilateral centrum semi-ovale and also in the splenium of corpus callosum without corresponding flare hyperintensity or restricted diffusion. The radiologist who read the scan quite appropriately called this is concerning for metabolic toxic encephalopathy. I would like to add that in a teenager who presents with stroke-like symptoms, one of the most important history to ask the clinical team or check on the electronic medical record is if this patient has underlying malignancy and has received recent methotrexate, either high dose intravenous or intrathecal administration. Indeed, this patient had received intrathecal methotrexate 1 and 2 weeks prior to the presentation to the emergency department. So the imaging appearances are most consistent with methotrexate related toxic leucoencephalopathy, including cytotoxic lesions of corpus callosum, which is known as CLOCC. In terms of methotrexate related CNS toxicity, it is seen in up to 4.5% of the patient. The risk factors, as we saw in our patient, is intrathecal administration and also high dose intravenous administration. It is commonly seen in pediatric patients, as we saw in our patient. There are 3 patterns of CNS methotoxicity. Most common is toxic leucoencephalopathy. Uncommon but rather devastating complication is disseminated necrotizing encephalopathy. And methotrexate can also secondarily cause B12 deficiency with imaging features attributed to B12 deficiency, as we know, is called a subacute combined degeneration of the cord. Hopefully I will show it to you in a future video. So in terms of methotrexate related toxic leucoencephalopathy, as I alluded, it's one of the common manifestations of CNS toxicity from methotrexate. It is usually seen in 2 to 14 days after administration of methotrexate, but rarely it can also happen many years after administration of methotrexate. So if you see characteristic imaging findings, it is important not to dismiss it if patient has not received recent methotrexate. Majority of these patients can be asymptomatic. So the imaging findings can be mild and transient. As we saw in our patient, there is true restricted diffusion. It can happen unilaterally or bilaterally across multiple vascular territories. Classic lesion would be restricted diffusion in centrum semi-ovale, which can be unilateral or bilateral. Usually will spare the subcortical U fibers. The T2 weighted and flare signal changes lags behind the findings seen on DWI, as we saw in our patient. Typically, the T2 weighted and flare signal changes will happen 48 to 72 hours after presentation. These findings can disappear or can persist after a few days of clinical presentation. As I alluded to before, most fulminant complication is disseminated necrotizing encephalopathy. Fortunately, this is a very rare complication. It is usually seen in the setting of intrathecal methotrexate therapy in combination with whole brain radiation. In this, there is extensive white matter signal changes. Within those white matter signal changes, there can be regions of T2 low signal intensity corresponding to hemorrhage, and there can be thick peripheral or solid enhancement with mass effect, and importantly, this should not be mistaken for an underlying tumor. So it is very imperative to recognize this is a complication related to methotrexate CNS toxicity. As we saw in our patient, there was also cytotoxic lesions of corpus callosum. It goes by various names such as transient lesions of splenium of corpus callosum, mild encephalitis with reversible isolated splenium of corpus callosum lesion with an acronym MERS, reversible splenial lesion with the acronym of RSL, reversible splenial lesion syndrome with acronym of RESTLESS. In terms of CLOCC, it has wide variety of etiologies including seizure, classically seen in the setting of either post-seizure or change to antiepileptic medications or sudden cessation of antiepileptics. It is seen in various metabolic disorders, infections, underlying CNS malignancy, classically in the setting of chemotherapy or associated seizures. Various drugs and toxins can cause it, including chemotherapy as we saw in our patient, and it can also be seen in the setting of subarachnoid hemorrhage, particularly if it's a large volume subarachnoid hemorrhage. So we saw this patient with methotrexate related toxic leucoencephalopathy who also had cytotoxic lesions of corpus callosum. I hope you found this case to be informative. Thanks for your attention.